All right. Well, it is my pleasure to welcome everyone to the February lecture in the Vermont Center on Behavior and Health monthly lecture series. Um, I want to welcome, of course, those who are in person here and those who are joining us remotely. We encourage everyone, all audience members, in person and remote, to participate in the Q&A session that we'll hold immediately after the lecture. As you can see from the screen, Dr. Brian Sprague is our speaker today, and he'll present on mammography screening, utilization in Vermont and beyond, long-term trends and COVID-19 impacts. As many of you know, Brian's a highly accomplished cancer epidemiologist who holds an endowed professorship in the University of Vermont Larner College of Medicine's Department of Surgery. Brian leads the Vermont Breast Cancer Surveillance System, a research program that collects integrated patient radiology, pathology, and outcomes data associated with all breast imaging performed at radiology facilities in Vermont. I read that for a reason. I wanted to get it right. And it's the reach of his research, it reaches into virtually every family in Vermont and beyond, and it certainly reaches into mine. So that's an impressive aspect of his work. His research focuses on development of personalized screening strategies that maximize benefit while limiting the harms associated with false positives and overdiagnosis, which are really considerable harms and matters to be taken quite seriously. Brian began an outstanding record of federal grant support when he first arrived at the University of Vermont some 10 to 12 years ago. I don't remember exactly when. And he's been continuously funded since. He publishes in high impact journals. He's the consummate team player, I know, because he's been a member in the Vermont Center on Behavior and Health ever since we organized it. And the thing that stands out in my memory most about Brian is the Vermont Center on Behavior and Health is funded by a Center for Biomedical Research Excellence from the NIGMS. And one charge of these center awards is to mentor early career investigators in getting their first R01, establishing themselves as independent investigators. And Brian established himself as an independent investigator before our notice of grant award arrived. So that's a unique distinction, maybe in the COBRE system. So, but it really is reflects on how Brian approaches his work and his productivity. So, Brian, thanks for being with us, and the floor is yours.
Thank you very much, Steve, for that kind introduction. Very happy to be here today. I'm going to talk about a topic that I thought would be a good one for this seminar series, and I wanted to bring to folks' attention studying mammography screening as a health behavior. And it's something that I've dabbled in my 10 or 12 years here, but hasn't been like the core focus of my work, which is mostly evaluating the performance of mammography screening and screening strategies. But this is something that, especially following the COVID pandemic, we've been continuing to study, and I wanted to put it out there to the experts in this group who think about things in different ways, and maybe you can help forge a path forward to further study this, because I hope to convince you that it's an important topic, and there's some action here that could use some more investigation. So just as an overview, I'll give a brief overview of breast cancer and mammography screening. I'll talk about the Vermont Breast Cancer Surveillance System, which Steve mentioned is the research program I run that studies breast cancer screening in Vermont. And then I'll get to our main results on reduced utilization of mammography screening in Vermont and beyond, both in relation to changing breast cancer screening guidelines and in relation to COVID-19. So breast cancer is the most common cancer diagnosis in women, affecting approximately 190,000 cases per year in the United States. It's the second leading cause of cancer death in women, with 40,000 deaths a year. So clearly a disease with a high impact in the United States. And we know from old randomized trials conducted back in the 70s and 80s that screening mammography reduces breast cancer mortality on the order of about 20%. And I'm just kind of noting that those trials were from the 70s and 80s, which were essentially the last controlled trials of mammography screening. And as you can imagine, a lot has changed since then. Most folks still believe that this order of magnitude reduction in mortality is there. It might be stronger given modern technology, but we've relied on observational data since that time to evaluate the performance of screening mammography. So just wanted to give folks an image here. So this is an example of an image from a mammogram of a 66-year-old woman taken in 2021. And just to get a sense of what a radiologist is looking at, it's a series of images like this. A mammogram is essentially a series of x-rays of the breast. And the job of the radiologist is to look at this and try to pick out something that looks suspicious. So you might think of cancer as a lump or a mass, but there's a number of ways that cancer can present on the mammogram. And the radiologist's job interpreting the mammogram is really to decide from this screening exam of a healthy woman, is there something suspicious here that we need to call back for further imaging and perhaps a biopsy? So this was the same woman now in 2022 with a screening mammogram. And if you're like me, you might look at these and think, I don't know, like, I don't know if either one of these is normal or abnormal. And it's one thing I'll allude to later is the idea of breast density. So that's the light appearing tissue in this mammogram, which like on the left is actually a normal mammogram. And that light tissue is just normal appearing, or it's normal tissue that appears light on a mammogram. And you could imagine it makes the job of the radiologist harder in picking out, is there a mass in here or is there something suspicious in here? The mammogram on the right actually contains an area that the radiologist flagged as suspicious with architectural distortion is what they call it, where it's not like you're seeing this glowing lump in the mammogram. The radiologist is really looking for subtle signs and trying to pick out something that looks different than last time. So it's helpful to have prior images to compare to, and then different morphological features that clue them into something, to carcinogenesis going on. So the goal of screening is to detect breast cancer at an early stage with the idea that treatment will be more effective if cancer is caught early. And we have a lot of statistics showing that survival from breast cancer is quite high if it's caught in an early stage. So in situ is non-invasive breast cancer, so it's still confined within the breast ductal system. And then there's different ways of staging breast cancer, ranging from that in situ disease to local, to regional spread, to distant metastases. And what we want to avoid is regional or distant stage disease, which often is presenting symptomatically. And just kind of going back into history, when screening mammography took off in the United States, it was kind of the late 1980s and through the 1990s, and then plateaued around the year 2000 at something like 70% of women self-reporting a recent screening mammogram. And at the same time as that dissemination of mammography occurred, there was a reduction in breast cancer mortality, which provides some support, ecological support for the contribution of screening to the decline in breast cancer mortality. And obviously it's hard to tease that out exactly, but various simulation modeling studies suggest that screening contributed to about 50% of that decline in breast cancer mortality, with advances in treatments contributing the remainder of that decline in mortality. So there are downsides to screening mammography that need to be weighed in considering who should be screened and when. Those harms include anxiety, small doses of radiation, and then what are thought to be more significant are false positives and overdiagnosis. So I'm going to kind of walk through some of the evidence regarding each of those. Overdiagnosis is the most controversial harm of mammography, and very hard, if not impossible, to quantify, because we don't know which cancers would have arisen symptomatically if they were not diagnosed through screening. But you can get a sense of the magnitude of this issue and why folks are very concerned about it just by looking at trends and incidence of breast cancer over time and thinking about that plot I showed of mammography screening increasing through the 1980s and 1990s. At around that same time, as screening disseminated, there was an explosion in cases at localized and in situ stage at diagnosis that were largely diagnosed through breast cancer screening. And one would hope that, okay, we're taking out those cases that would have been diagnosed at a later stage, later in time. But when we look at the trends for regional and distant stage disease, you can see there's some slight decrease in regional stage disease, but distant disease has been pretty constant and is nowhere, the magnitude of changes in regional and distant disease are nowhere near the increases we've seen in localized and in situ disease. So there's a lot of concern that many more women are being diagnosed with breast cancer who would not ultimately have had symptoms of that breast cancer. So that's what I mean by overdiagnosis. So that's a very controversial topic and hard to quantify. But just kind of looking at this plot, you can think, ooh, there's something going on there that we should be concerned about. So concerns about those harms and weighing those harms against the benefits, I've kind of titled this Life's Persistent Questions because as someone who studies breast cancer, it's like these same questions for the past 20 years, really, that we're trying to answer. Who should get mammography screening? When should they start? How often should they get screened? And when should they stop? And that's what we try to address through the Vermont Breast Cancer Surveillance System. This was started back in the 1990s by Berta Geller, Sally Hirschhorn, Don Weaver, and others. It really such an impressive accomplishment to bring together the breast imaging clinics throughout the state and get them to agree to share their data with us here and participate in what was designed as like a quality assurance and a research program to help support these breast imaging clinics by providing feedback on their performance and also allowing us to use that data in research. So locally, we call it the Vermont Mammography Registry is how we're known. And it's entirely funded by NIH research grants, which makes it more impressive that it's been kept going for so long because it really is every 5 years trying to convince NCI or PCORI or somebody to give us another 5 years of funding to keep collecting data from all the facilities around the state. So it's kind of a nerve-wracking enterprise that keeps the grant writers busy. And just wanted to highlight the partnership with its 13 different breast imaging practices around the state, 8 pathology facilities that interpret breast specimens. And we also partner with the Vermont Department of Health to collect data from the Vermont Cancer Registry and vital statistics. As I mentioned, it's a multidisciplinary team of investigators, folks from radiology, pathology, biostats, and surgery. And I'll talk more. These are some of the national consortia that we participate in over time, particularly the Breast Cancer Surveillance Consortium is one that was founded in 1996 along with the Vermont Mammography Registry. So it all kind of rose at the same time. And we've continued to partner through that consortium ever since. So I'll be showing some data from that group. And just want to give you a sense of the data that we collect in the registry. It's wide ranging, including self-reported information from women attending breast imaging visits. We collect data from the radiology facilities about the exams performed and the results of those exams. We get copies of breast pathology reports for all breast specimens. As I mentioned, we link with cancer registries and state death tapes. We use geospatial data sets based on patients' area of residence to pull in census level information or other information on like community level social determinants of health, for example. We also link periodically with claims data. And finally, we have a variety of ancillary studies where we'll pull in additional things like radiology images or tissue specimens. So this is kind of a huge operation to put all this together. And we have a great staff down in UHC who handles all of this data coming in and puts it all together, including scanning of paper forms, importing electronic data extracts, doing medical records abstraction for pathology reports, and all these algorithms to try to link women who are seen at different facilities in the state at different points in time, and pulling that all together, checking for errors, validating the data, and organizing it in relational databases so that we can produce analytical data sets. So I definitely want to acknowledge my staff who make all this magic happen and produce nice little data sets for me to analyze. So it's been going on for over 25 years, and we've accumulated a lot of data. It's roughly 80,000 women and 500 breast cancers per year that we see. So those numbers add up over time, where we have data on over 200,000 women, 1.5 million mammography exams, and about 10,000 breast cancers. So the Breast Cancer Surveillance Consortium is a national group we participate in. It's grant funded, and we're actually the only statewide registry in the consortium, but there's other regional registries that collect similar data like we do in say San Francisco or in Northwest Washington. Dartmouth has one of the other registries. So we all pool our data together annually, and then we're able to do research that really is more nationally representative and of course has quite large sample sizes. And just wanted to kind of put out the main focus of that group is evaluating performance of breast cancer screening modalities, both mammography and other technologies, looking at how screening performance varies by provider and patient factors, and developing risk prediction models for screening outcomes. For example, advanced cancer. So one of our areas of focus is trying to provide evidence that could support more personalized screening strategies. So in theory, using risk prediction models could help guide women towards more intensive or less intensive screening, depending on their level of risk of breast cancer. And we produce all this evidence trying to inform women, providers, and policymakers about the outcomes that would be associated with different screening strategies. So those include the US Preventative Services Task Force, the American Cancer Society, American College of Radiology, and let's see. Now I'm kind of gonna go back in time a bit and walk you through some of the studies we've done chronologically as guidelines have changed over time. So this is kind of my like pre-2009 situation where for longer than I've been around, the American Cancer Society has recommended annual mammography for all women 40 and older. And prior to 2009, the task force recommended mammography for women 40 and over every 1 to 2 years. So that had been the status quo for quite some time that everyone was used to. But the task force and the Cancer Society meet periodically, and they reevaluate the evidence and come up with updated guidelines. I also want to mention the American College of Radiology also has always recommended annual mammography for women age 40 and older. And let's see. So, okay, yeah, weighing the benefits and harms. So around 2009, when the task force reevaluated their guidelines, they really took a hard look at the evidence on how mammography screening performance varied by age. I've pulled up the data from a more modern paper here, but the trends have been the same. And what is known is that the rate of false positives for screening mammography are higher among younger women, and the rate of true positives are higher among older women. And you can see the magnitude of these differences in that you're much more likely to have a false positive mammogram than you are to have cancer detected on the mammogram. Which doesn't mean we shouldn't do it, but it just means this is kind of the magnitude of the balance of harms and benefits there. And some of the reason behind that is getting back to breast density. So women who are young tend to have higher breast density, so mammograms appearing more like the one on the far right, which make it much more harder to see a cancer and also make a lot of things look suspicious that turn out not to be cancer. Whereas older women tend to have less breast density, like the images on the left, where it's easier to pick out a cancer and there's less suspicious findings that ultimately are not cancer. And the other factor is the patterns and incidence of breast cancer with age. So like most cancers, incidence of breast cancer increases with age. So you can imagine applying a screening test to younger women, say ages 40 to 44, they're much less likely to have cancer than older women. So when you apply that screening test, the rate of true positives for older women is much higher than it is for younger women. And when you kind of back out the numbers and think about how many patients need to undergo a mammogram to diagnose one case of invasive breast cancer, you can see you have to screen a lot more younger women to find that one case compared to older women. We've also looked a fair amount at screening interval. And most of the discussion has been around annual versus biennial screening. And this were some interesting findings. Here I'm stratifying by menopausal status, and finding that, as you might expect, women who are screened annually have less chance of having advanced stage disease or a large cancer compared to women who are screened biennially. So that kind of makes sense. Amongst postmenopausal women, it was somewhat surprising, but those cancer characteristics are actually much more comparable and very little difference in the stage at diagnosis for women undergoing annual and biennial screening. And it's thought that that's related to the notion that cancers tend to grow more rapidly when they do develop in younger women, whereas amongst older women, they tend to be slower growing cancers. So catching it, 16 months versus 6 months, it's not a big difference in terms of the stage of diagnosis. So that's some of the evidence that led the task force to change their guidelines in 2009, which was very controversial and generated tons of media attention and scientific attention. But they changed their guidelines to essentially recommend routine biennial mammography for women ages 50 to 74, whereas for women 40 to 49, they recommended that be a personalized decision made by a woman and her healthcare providers, in which they took into account the harms and benefits and the woman's values and preferences. So that was a very controversial decision, both in terms of is it the right thing to do, and how are we supposed to implement this, informed discussion making when we have primary care providers quite busy trying to, this is just one issue. There was an interesting article, I forget if it was in the New York Times recently, about adding up everything a PCP is supposed to discuss with their patient, and it's would take you 27 hours to address that or something if you followed all the guidelines. They also concluded that there wasn't enough evidence to say one way or another whether women 75 and older should get a screening mammogram. So we did some work looking at the potential impact of that change in screening guidelines on screening utilization in Vermont, and just wanted to note how we're doing this. With the registry, we receive data on all women undergoing breast cancer screening in Vermont. We don't necessarily have a defined denominator for that, but we can use the census estimates for the Vermont female population to know, okay, we have a statewide registry. Hopefully we're capturing exams that occur amongst the residents of Vermont. So a slight caveat about our data, but we think it's a valid approach. And this is what we found, that there had been this steady rise in utilization of screening mammography in Vermont that changed after 2009 when the task force guidelines came out. You can see the decline both in screening in the past 2 years and screening in the past year. So just to interpret this clearly, in 2009, 60% of women aged 40 and older had a mammogram in the past 2 years. And by 2011, it was down to about 55%. And we were interested to break this out by age related to the screening guidelines. And here I'm showing percent screened within the past year. And we saw declines in each of the age groups, although as one might expect, it was sharper amongst women ages 40 to 49, but not all that different in the other age groups. And kind of the most important metric, percent screened within the past 2 years, again, we saw the steep decline amongst women aged 40 to 49, and more of a harder to interpret result for women 50 to 74, where our join point regression didn't identify a declining trend, but you look at that last data point, and it's certainly heading down. And if you just focus on that and compare the 2009 to 2011 screening rates amongst women 50 to 74, there was a decline from about 65% in 2009 to about 61% in 2011. We also looked at changes in screening interval. So here I'm showing for ages 40 and older. And what we were looking for was to see if women were adopting this biennial screening interval. And for folks not familiar with this, it might be somewhat surprising to see just how common annual screening is versus other screening intervals, despite the recommendation for biennial mammography by the task force now. And there was really this decline in women attending annual screening exams with no increase perceptible in the rate of women attending biennial or longer screening exams. In a follow-up paper, we broke this out by estimated breast cancer risk of women attending mammography. So using a simple risk calculator that takes into account family history of breast cancer and other common risk factors, we stratified women according to their level of risk. And we found that the strongest decline in attending mammography was amongst low-risk women, but we also found declines in other groups, average, intermediate, and high risk women as well, that were not as strong, but also still present. So zipping forward a few years, in 2015, the American Cancer Society went through their process and changed their screening guidelines. And in part based on that evidence I showed you about stage-like diagnosis versus screening interval, they felt that younger women should attend annual screening to try to catch those rapidly growing cancers, whereas older women could attend biennial screening. So they shook up their recommendations a bit, and also by essentially shifting the start age from age 40 to 45. So and this is, like I mentioned, kind of a pet project of mine where we just keep kind of checking in on it to see how things are changing. And so here's just an updated version of those plots. And you can see there were some changes in the 40 to 49 group after the American Cancer Society guidelines came out. But for me, the biggest takeaway from this was just seeing that 50 to 74-year group, which is in the red line. I showed you the results through 2011 and previously, and now here in this update, you can see it's just continued to tail off over time. By 2017, we're down close to 60% from this estimate. Again, looking at a screening interval, very similar, just continued decline in the rate of utilization of annual mammography with no corresponding increase in biennial mammography, which is the red line on this plot. So our conclusion there was that we're seeing steadily declining mammography screening rates in Vermont since 2009, including this age 50 to 74 age group where there's discordance in the screening recommendations, but everyone thinks women's 50 to 74 should at least have biennial screening. And we're seeing a decline in that metric over time. So it's one hypothesis is that there's a spillover effect, that all the scientific debate and the media attention regarding mammography's harms may have led women and providers to overgeneralize those findings and messages and perceive that screening is not as effective for women 50 to 74, maybe be less aggressive in pursuing screening. It's also possible that efforts to de-implement screening for women 40 to 49 and 75 and older could have spilled over towards less intensive outreach for women 50 to 74. And you might not think about it, but it's been interesting to learn from screening facilities how challenging it is for them to target, say, like their reminder systems, where they can either send out a reminder to everyone to get, schedule your screening for next year, but they can't tailor it based on basic things like age, or it takes them time to adopt new systems that can do that. So I've been working with Sarah Nowak, who's very interested in these possible spillover effects and issues around de-implementation. And we've looked at some national data from the behavioral risk factor surveillance system to investigate this on a national level. Here, showing the national data. So this is self-report survey data asking women if they've been screened within the past 2 years. And first of all, we found similar phenomena compared to what we observed in Vermont, with screening adherence dropping after 2009. And what we did was we compared this rate of decline in 50 to 74-year-olds for each state across the country. So giving us 50 data points and comparing the rate of decline in the 50 to 74-year-olds in each state to the rate of decline in the 40 to 49-year-olds, which is plotted on these charts here. So to try to orient folks, in panel A, on the y-axis, we have the percent point decrease amongst ages 50 to 74, and you can see the bulk of the data appear to be negative, so a decline in screening over time. And we're plotting that against the decrease in screening amongst ages 40 to 49. And we observe this correlation between the two. So states that had the strongest declines in screening amongst women in their 40s tended to have the larger declines in screening amongst women ages 50 to 74. And the same was true when we looked at the decline in screening among ages 75 and older, as shown on the right side. So, Sarah and I interpreted this as consistent with a potential spillover effect. Obviously, there's a lot of reasons why the two could be correlated, but she's particularly interested in examining whether those efforts to de-implement screening amongst women in their 40s and 75 and older trickled over to influence screening for women's 50 to 74 in the target group. So that kind of brings us up data-wise to 2020, when COVID hit, and was another chance for us to do some more work in this area. And I led some studies in our national consortium to look at screening mammography volumes during the pandemic and compare that to pre-pandemic volumes. So I'll show a series of figures that look somewhat like this, where the black line represents screening volumes in 2019, and the red dotted line is screening volumes in 2020. And as you can imagine, in April of 2020, essentially screening shut down in the United States for mammography. And we saw a 99% decrease. So just orienting you, that 1.1% is kind of the 1.1% of the expected screening volume for a normal year. We found that there was a pretty, all things considered, rapid rebound in screening volumes. So by summer, by July of 2020, we're back up to 90% of expected volumes. So a real, sudden, deep decline, but a pretty rapid bounce back. And which sounds nice, but then you look at the cumulative screening mammography volume over time, and you kind of realize that to get back to normal, there was basically this group of women who missed their screening exam for this 3-month period, and to get back to normal, we'd have to get those women in if we're going to get back up to a true 100%, thinking about it in cumulative terms. And so when we look at it that way, we could see that, on that basically a half year's worth of data, we lost about, a third of our usual screening volume. So that's a little more disturbing. We looked at variation by patient factors. So on the bottom left there is that same sort of plot by age, and we found really similar patterns by age, which was a little surprising. We thought maybe older patients might be less likely to come back in for screening if they were more concerned about COVID. We didn't see much difference by family history of breast cancer, just kind of using that as a prominent risk factor. But we did see variation by race and ethnicity, with that rebound slower and less complete amongst Asian women and Hispanic women. We then took it a step forward to look at breast cancer diagnoses during the pandemic, again, using data from the Breast Cancer Surveillance Consortium, including our Vermont data. And the results largely mirror the screening volumes, as you could imagine. So there was a substantial drop in breast cancer diagnoses in April with the onset of the pandemic. It bounced back pretty rapidly. The cumulative volume was down by about 20% through September of 2020. And here we're splitting it out by whether the cancers were screen detected or symptom detected. So the green lines are screen detected cancers, which you can imagine had the largest drop in volumes through the pandemic. whereas the symptom detected cancers, there were declines very quickly in April and into May, but those bounced back as kind of healthcare came back online and women were able to get into facilities in June and following that year. And when we look at it cumulatively, that cumulative rate of symptomatic cancers pretty much caught up by July of 2020, whereas the rate of screen detected cancers was quite depressed through September. So about 25% less screen detected cancers than would occur in the normal year. And in this, we also saw variation by race ethnicity, where the change in total cancers detected was least impacted amongst non-Hispanic whites and more strongly impacted among other racial and ethnic groups. Taking it another step further was to think about the potential long-term impacts of those changes in screening utilization and cancer diagnosis. And for that, we partnered with SysNet, which is a group of simulation modeling groups that takes available evidence on mammography utilization and screening performance and treatment effectiveness and puts this into a model of the US population. So essentially running women through this simulation where they're followed over their lifetime to see what the long-term outcomes would be. So things like breast cancer mortality and quality adjusted life years and things we can't easily measure in observational data. And we looked at a few scenarios associated with COVID. One is kind of our observed reduced screening scenario. And here we're just looking at really short-term impacts of COVID. And we did this pretty rapidly after the onset of the pandemic, where we had no idea what was happen next, but we knew like, okay, there were disruptions to screening over the 6-month period. Let's see what the long-term impacts of those might be. In addition to looking at reduced screening, we looked at delays in diagnosis for women who had symptoms, who weren't able to get those symptoms worked up promptly, and also changes to some treatment strategies that were impacted in the acute phases of the pandemic. And what we found, if you focus on kind of the top circle of reduced screening, was that like short-term reduction in screening over that 6-month period was predicted to contribute to 950 excess deaths amongst our entire US simulated population, which would be about a 0.2% increase in breast cancer mortality. There were slightly larger excess deaths due to delays in diagnosis of symptomatic cases, and then a small impact of the more moderate changes to treatment strategies. And when we put all those three together, we estimated about 2,500 excess deaths due to like the short-term acute impacts of the pandemic on breast cancer screening and diagnosis and treatment. And it was kind of interesting. You know, we kind of felt like that's not too bad, 0.5% increase. But it was interesting to see that information cited in literature kind of rapidly about there's going to be 2,500 excess deaths. That doesn't sound very good. So it's kind of in the eye of the beholder, I guess. Obviously, we don't want excess deaths, but it was a smaller magnitude than we were worried it would be. So this is just a summary on that piece. We did see this decline in screening mammography, but a pretty good rebound rapidly through the summer following the pandemic. Although notably, it was not clear that a full recovery in volumes had occurred. So by September 2020, we were still at kind of 90% of expected volume. Which brings us chronologically up to another series of studies I've just been delving into recently, looking at how we're doing now that we're a couple of years out, 2-3 years out from the pandemic. And we have our 2021 data that we've been looking at. These plots on the left show percent of women screened in the past year. You can see that dip in 2020 with the pandemic, a bounce back in 2021, but noticeably still lower than we were at in 2019, when we're thinking just women screened in the past year. On the right is women screened in the past 2 years, and which I like because it's kind of the metric that corresponds to the task force recommendation. And in 2021, we're down to below 60% of women now meeting that recommendation. Looking at screening interval, like I showed you previously, as you can imagine with the pandemic, there was a sharp disruption to annual screening because women couldn't get into the clinic in 2020 frequently. So by the time they could get in, it was more likely to be a biennial, characterized as a biennial screening mammogram. So we did see this increase in biennial screening in 2021. But again, I don't think that's due to intentional biennial screening. I think that's women who skipped their exam in 2020 and came back in 2021. We were interested to see if there were certain patient factors that were associated to returning to screening after the pandemic. So whether this rebound in screening varied across patient characteristics. So we pulled out a cohort of 96,000 women who were screened in Vermont during 2018 to 2020 prior to the pandemic. So up to something like February of 2020, and looked at what proportion of those women returned for screening by the end of 2021 and which patient factors were associated with a higher likelihood of returning to screening. And I've listed some of our findings here. And again, this is unpublished work that we're trying to sort through and make sense of. But some of our findings are that women on the more extreme age ranges were less likely to come back in for a screening mammogram. Women of non-white race and Hispanic ethnicity were less likely to come back in for a screening mammogram. Those with lower educational attainment. Interestingly, those with metropolitan residents, which is interesting. This is Vermont data again, so thinking about our metropolitan population, but Burlington and some of our other small cities qualify. But yeah, I was curious. I was expecting that it could be, typically we're looking at disparities in our rural population. So it was interesting to see that this was the case here. And finally, low risk women were less likely to come back in for a screening mammogram compared to average risk or higher risk women. So just to kind of wrap all this up, and again, this is kind of like this interesting path I've walked down following this data. And I'm curious to engage the center and folks in the center more with this and figure out what to do next. Basically, we've seen this long-term trend towards reduced screening mammography use in Vermont and the US. And we now estimate there's about 57% adherence in Vermont in 2021 for at least every 2-year screening amongst women aged 50 to 74. So that task force recommendation. And we continue to see little uptake of biennial screening, with the exception of this little bump following the pandemic that I think is just due to the disruption in 2020. We've looked at the pandemic impact, which we think the direct impact was relatively small. However, we've noted this disparity in the rebound in screening utilization that we're worried about that could lead to increasing disparities in breast cancer outcomes. And overall, it's really unclear to me at this point what's driving declining screening adherence in Vermont and nationally. I'm sure the controversies around the guidelines haven't helped. I don't know. I honestly don't know what the other factors are. We've looked at it in a variety of ways using the data that we have, but I'm really at a point where I feel like, hey, this is kind of a problem that needs some more attention. It could be capacity issues. It could be mistrust of institutions. A whole host of factors could be contributing to this. And then finally, I just wanted to note the task force is currently reviewing their breast cancer screening recommendations again. So it could be another, we have no idea what to expect if they'll change their guidelines substantially or not, but it could be another period of shakeup coming in the next year or so. So we'll see. I want to acknowledge a lot of collaborators involved in this work, particularly Sarah here at UVM, also Katie Lowry at the BCSC, who led some of the COVID work, a number of trainees. This is like one of my usual trainee topics because I don't really have grant funding focused on this utilization piece, but I'm so interested in it. I like to say, oh, if you've got time, why don't you poke around in this data some more? So great work by these trainees I've listed. and of course our staff at the VMR, who have just had great dedication and continuing to put this data together, including during the pandemic when it required a lot of adaptability to be able to continue to collect this data, working remotely and developing all sorts of new solutions. And finally, funding from the Cobra Center here, which I appreciate, as well as the National Cancer Institute and PCORI. And with that, I'll be happy to take any questions.
Okay, well, this is Phil Ada's offsite. Can you see me and hear me?
Yep. Hi, Phil.
Especially hear me? Hi, Brian.
Yep.
First question I have from one of our viewers is a good question. Has insurance coverage for screening changed with the changing recommendations? Insurance coverage seems to guide a lot of healthcare decisions.
Yeah, that's a good question. Actually, screening coverage for mammography is good and has not changed in that women, it's a covered screening procedure. It was before the ACA, but the ACA kind of reaffirmed that and requires insurers to cover that. There has been some complications in that often the screening exam is covered, but it's been less clear and there are gaps in coverage when the screening exam leads to a diagnosis that leads to diagnostic workup and treatments. And if that's not covered, that leads women to, reasonably reconsider attending screening if they are worried that any follow-up care is not going to be covered. So there's frequently initiatives, and I believe there's one in place in Vermont that mandates that follow-up of screening. Screening mammography is covered now, but
okay.
So Phil and I are alternating remote and in person. Is there a question from the live audience? Eli. Oh.
Thanks for a great presentation. Learned a lot just watching this year and thinking about the 57% of women or so who are attending regularly their screenings. Do you know of any work that's being done to identify what they find helpful in reminding or getting them in, or conversely, the folks that are not attending, what they see as barriers? Thinking about how to address this in the future.
Yeah. I'm not, so hopefully everyone could hear the question about what women may identify as barriers to getting into screening, and conversely, women who do attend screening, what the facilitators are, I think is what you're asking. And I don't have a great sense of that. And I think it's an opportunity to do more like focus group work or survey work. We've done some patient engagement around the breast density topic in particular, but less so about general attitudes with screening adherence. So I think that's a great suggestion. I do think one of the interesting drivers of screening has been when you attend one exam, the radiology clinics are usually the most aggressive group, and they follow the American College of Radiology guidelines, who want women to get screened every year. And they often attempt to schedule you, for your next yearly appointment as you attend your current appointment. So I think that's really driven like the continued high rates of annual screening and why we don't see much of a switch to biennial screening. And I'm not sure, to my mind, the clinics continue to try to promote annual screening. So I don't think that has changed over the past, but I do think patients are getting mixed messages when the radiology facility tells them to come back in a year. Maybe their primary care says 2 years is fine. And maybe they've read some articles that, say that we've got to be worried about overdiagnosis and false positives, and things get murky. Yeah.
Okay, Brian, I have a question of my own.
Sure.
You can hear me? Okay. I always get frustrated by guideline panels that conclude regarding some major healthcare decision that you should speak to your doctor. and you and your doctor will come to a decision, when in fact that doctor was reading this guideline panel report to give him or her information to make that decision. And I know in cardiology, when we're making a decision to treat someone or not with a statin, we have computer apps that we can use to quickly give us a 10-year risk of an acute MI. And if it's above a certain level, we treat with a statin. Is anything like that available for women, where you might punch in age and menopausal status and family history and come up with a 10-year risk of breast cancer, and maybe screen people who are higher more often and so forth? That would be
Yeah.
very helpful, I would think.
Yep. Yeah, great question, Phil. So that's what we've been trying to produce in our BCSC efforts. And first, we developed a 5-year risk calculator that takes into account something like 6 or 7 prominent clinical risk factors for breast cancer, and that's publicly available as on a website and as a iPhone app and things like that. And there are a few other breast cancer risk calculators that are used in clinical practice to somewhat guide screening decisions. But more recently, we wanted to take that to the next level to say, aside from your general risk of breast cancer, like what's the likelihood of different screening outcomes depending on what screening regimen we choose? So our latest effort has been to develop a calculator for advanced breast cancer risk, because we think, ultimately that's really what we want to avoid. We don't want late stage breast cancers. If a woman develops a symptomatic early stage breast cancer, that we have good treatments for, but we really want to avoid those later stage disease outcomes. So we just published last year in JNCI a risk calculator for advanced breast cancer risk that takes into account those clinical breast cancer risk factors and also your screening interval. So you can look at, okay, if I do annual screening, this is my likelihood of an advanced breast cancer over the next 6 years. We actually did for that model. So you could compare like 6 annual screens versus 3 biennial screens versus 2 triennial screens, to try to get a sense of what difference it makes in terms of that outcome. So yeah, that's definitely the kind of work we like to do. And we're hoping to, and again, we put that out there as a web calculator, and we're developing the iPhone app now. So we're hoping things can move in that direction and really that's what we want to do, is provide this evidence. I'm not really in the business of making these recommendations or saying what we should do, but I can tell you what the likely outcomes are under different regimens.
Brian, I have a question as well. Or a comment and a question. So my comment as a behavioral scientist, when I look at what's transpired, I just think you introduce, not you, but the forces that be introduced complexity, took what had been a simple regimen, easy to remember, easy to get uniformity across providers or other people who may be consulted about when the woman should go. So you've got complexity and some confusion potentially. Is there any way to parse that out? Because then you could do like the benefit, you could weigh the cost of whatever you could attribute to the cost in terms of non-adherence from the effort to personalize, which is, so that would be the task, but to try and sort that out.
Yeah, I think that's a great point, Steve. I think that's like the critical tension in the field, is there's been a big drive towards personalization, but when you think about implementation of that, it's really a bear. And I don't know how to parse out what the net benefit would be, going in either direction. We try to do that a bit in the simulation modeling to say, we can look at rates of adherence and just use estimates of like, well, you make it complicated, you're going to lose folks. And that's not even getting into the costs, which we also try to look at of implementing, risk assessment at visits. So
Maximum, keep it simple unless you have good reason to complicate it.
It's tricky. I can see the arguments both ways,
right,
for sure.
Bill, back to you. Any questions still?
I have
from the remote?
nothing left. That was it for me. Thank you.
Okay. And Diane?
All right, so you mentioned that, using the data from the COVID time of not screening to look at potential excess deaths. But to get back to the possible overdiagnosis and excess screenings, have you also kind of used that natural dip in screenings to model what the other side of it might be?
Yeah, we didn't model overdiagnosis as an outcome, although we could have, and maybe we probably have those outputs, but we didn't publish them. But we're really interested now in terms of the observational data is seeing how that deficit I showed in screen detected cancers. We're getting into the time period now. Okay, it's been 2-3 years. We might start to see those cropping up as symptomatic later stage disease cases. It takes some time to be able to see that, but that's what really everybody's interested in from like the natural experiment kind of situation is like, are we going to see this bump or not? Because if we don't, then it's like, we took 6 months off from screening and awful things didn't happen. Maybe
Wasn't so bad.
yeah, but in part, it also depends on the patterns of women coming back in for screening.
Well, obviously you want them to come back in, but it seems like you do have a natural experiment there to look at the other side as well. So.
Yeah, but just that it requires us to understand is it everybody taking a year off, or is it some people getting back in quick and other people not coming in for 4 or 5 years? Those kind of patterns that make a difference.
Yeah, one more question. Still thinking about some of the barriers. You showed some pretty clear disparities in different groups in Vermont in terms of screening, and wondering about how aversive false positive is. And I don't know if you have any insight around whether that's a similar process across false positives, or is there a range in terms of how far that goes before someone realizes this is actually cancer?
Yeah.
Thinking about whether those experiences might be consistent across populations or consistently keep people from coming back in for more screenings later.
Yeah, that's a great question. I don't know how those experiences vary across like the social demographic groups I showed, but we have done some work looking at the influence of a false positive on future attendance in general. And it's interesting in that experiencing false positives that just require additional diagnostic imaging are generally not associated with changes in future adherence. But experiencing false positives that require a biopsy, that tends to lead to less adherence in the future. And particularly if there's multiple false positives with biopsy, that's where we see really stronger effects. But it's kind of interesting on the flip side. I think most women who experience a false positive, especially if it's just additional imaging, feel reassured and ooh, that's good. I don't have cancer. Like, I'm happy. I'm going to keep coming. But if you have to go through invasive procedures and then you get to the end of that and think, oh, there was actually nothing wrong, and I went through all that for no good reason, in quotes, then that turns people off. Yeah. But I'm not sure if that varies across groups. Yeah.
Hi, thank you for that talk. This is more of a comment, but when you're talking about kind of barriers, one other thing I feel like has changed since COVID is just access to primary care. So, we talk about insurance, but thinking about patients who don't even have a primary care physician and relying on the primary cares to, be helping patients get into that initial screening program. Like you said, once they're in, they're usually tied in, but this does seem to be another dynamic that's changed.
Yeah,
since
I think that's
2020.
a great point and something we're going to try to look at in this work with Sarah. And I certainly, from a personal perspective, I experienced that where it's like impossible to find a primary care provider. And I've had so many people, say like, oh, you work at the hospital? Like, can you get me into a primary care clinic? Like, it seems pretty rough out there. So yeah, great point.
Just a word of encouragement to our behavioral science trainees. If you could think of a way to model these behavioral factors, NCI funding, it's really interesting. I have to admit, I never thought about some modeling along these lines, but I'm confident, maybe for the obvious, that what I mentioned about adding some complexity is a factor in that if you think about it, every other year, you have to emit a response one year and withhold a response in the next year. So just that description, it describes the complexity in the behavioral task. But anyhow, a wonderful talk. Your data is just fascinating. Your careful approach is inspiring. So very good. And thanks for sharing it.
My pleasure. Thanks, Steve.